You had a talk today on the management of diabetics with multivessel disease, the CSI. So, sir, what's your in your clinical practice? How commonly you see this kind of patients, the diabetic patients coming with multivessel disease?
Actually, 30 to 40% of the patients with coronary artery disease, which we see in the cath lab after angiograms, have diabetes. This is a very well-known fact in any major high-volume cardiac center. So it's a very common association.
Right, sir.
And diabetes has always been a challenge, especially when the patients have coronary artery disease.
Right, sir.
In terms of management, in terms of whether you do bypass surgery or you do angioplasty, their risks are clearly more than the patients who do not have diabetes.
Right, sir. So before coming to the invasive procedures, what about the medical management for these patients, sir? How do you follow?
I think in the last decade there has been a tremendous progress in the medical management of the diabetics with coronary artery disease, and that has really resulted in improved outcomes. Let us start with the antiplatelet drugs, because diabetics have a milieu of more thrombosis. Diabetics are more prone to stent occlusions,
Right.
restenosis. Now we have antiplatelet drugs which are superior to clopidogrel.
Right.
And in patients of diabetes with acute coronary syndrome, which is a very common association, it is very clear that prasugrel and ticagrelor are clearly superior to clopidogrel. They improve the outcomes. They in fact also reduce the mortality. The Plateau study has very clearly shown that the mortality is reduced, and even the Timmy-Triton study has shown that in diabetics with acute coronary syndrome, if prasugrel is used, their improved outcomes are very clear and the bleeding risk is not higher. So that is number one. Number two, most of the cardiologists now are convinced to use high-dose statins in diabetic patients and for long terms. There was always a tendency of using lower doses.
Right.
And we did a study, and which is the only study where 40 milligrams has been compared to 80 milligrams.
Okay.
And it's not a very long-term study, it's for 6 months.
So 40 milligram of rosuvastatin?
No, 40 milligrams of atorvastatin versus 80 milligrams of atorvastatin. And it was seen that there was hardly any difference between the tolerance of 80 versus 40. And today we know that it is the 80 milligrams of atorvastatin which is evidence-based, time-tested, proven to reduce the events.
Right.
So that is also very clear. Number three, diabetes and hypertension is a very common association. We also call it as a malignant duo.
Right.
And more cardiologists and physicians today are convinced that ACE inhibitors or ARBs is the way to go. So all that improves the outcomes, reduces nephropathy, reduces renal failure. So that is a very, very good news. And finally, I would like to say there has been a revolution in the management of hyperglycemia.
Right.
We used to have a lot of drugs, but they all would just control the sugar and possibly not harm the patient. Actually, some of the medicines had shown that they could possibly harm the patient. And that is why the FDA USA had a mandate that any new drug which comes for the management of diabetes, one has to show that it is at least not harming the patient.
Right.
Today we have drugs like empagliflozin, which has clearly been shown in the EMPA-REG study that it not only reduces the HbA1c by around 0.8 to 1%, but also improves the survival.
Right.
It reduces the cardiovascular mortality,
Right,
and that is a big thing. Similarly, GLP-1 blockers have been shown to improve the outcomes that liraglutide has been very clearly shown to be. So this is some of the revolutionary things that drugs can improve the outcome.
So, sir, for your the antiplatelet therapies, the DAPT, which is recommended nowadays for the ACS or post-PCI patients, for the diabetic multivessel disease, typically how long do you prescribe this?
It's a very important question. When we use DAPT, we have two aims. Number one aim, if the patient has had a angioplasty with stenting, is to reduce the chances of an occlusion, stent thrombosis, and that with the new drugs, newer stents,
Right.
is possibly not required for a long period of time because they heal very well. Like with everolimus eluting stents from many companies, they all have been shown that maybe 6 months is enough and even 3 months may be enough.
Right.
But when we are doing angioplasty of a patient, we are just handling a short or small segment of the coronary arteries, maybe 18 millimeters, maybe 40 millimeters, 60 millimeters. But we have miles and miles of coronary arteries,
Right.
and they are all rich with plaques. Many of them are vulnerable plaques. Many of them, get occluded. So comes the question of longer term dual antiplatelet therapy. And studies have shown that longer term dual antiplatelet therapy, if the bleeding risk of the patient is low, is possibly beneficial. There are at least 2 studies, the DAPT study, which showed that if you continue dual antiplatelet therapy beyond 1 year, the chances of stent thrombosis are lower, the chances of repeat revascularization are lower, many things are lower, but there is a little higher chance of bleeding. So if you can identify those patients who have high chance of bleeding, like females, like patients with kidney disease, renal failure, patients who have thin body weight,
Right.
patients who are in heart failure. Similarly, there are many other things.
Right.
If you can, there's a DAPT score. If the DAPT score is low, then I think there is a place to continue dual antiplatelet therapy for a longer period.
Right.
Similarly, the Pegasus study with ticagrelor has once again clearly shown that beyond 1 year in patients with myocardial infarction who have had a MI in the remote past,
Right.
if they are continued with 60 or 90 milligrams of ticagrelor twice a day, the clear benefit on survival is there up to 2 to 3 years.
Right.
So dual antiplatelet therapy, the length of it is undergoing a revision.
Right, sir.
Although we don't have the last word on it, but at the same time, I must say that it has a very bright future,
Right.
and I think dual antiplatelet therapy is going to be very important, and possibly drugs like ticagrelor. There are some studies going on which suggest that we may not require aspirin. The combination of aspirin and ticagrelor, only aspirin adds to the bleeding. It doesn't do anything in efficacy
added
because
advantage.
ticagrelor is so efficacious itself. So writing on the wall appears to be that even one antiplatelet drug started from the beginning and continued like we continue aspirin in all the patients with ischemic heart disease may be good enough.
That's a good point, sir. So now, sir, after the medical management, if we come to the invasive therapies or invasive management, so what's your take on the PCI or for this multivessel disease? Do you recommend PCI with multi-stenting, or patients are referred for the CABG?
See, if we look at the past, it was very clear that diabetics with multivessel disease were better treated with bypass surgery. The
Right.
FREEDOM study had very clearly shown with the first generation drug-eluting stents which were used in that, CABG had lower mortality. But the newer stents have clearly changed the scene. In one of the landmark studies with which I was fortunately involved, I was the national lead investigator, a study called Tuxedo, published in New England Journal of Medicine last year in September. We clearly showed that when everolimus eluting stent Xience was compared with paclitaxel eluting stent Texas element, it was very clear that Xience was clearly superior. Otherwise, there was a belief that paclitaxel eluting stents in diabetics are possibly equivalent or maybe better. But this study very clearly showed that the new generation everolimus eluting stents have much lower stent thrombosis, much lower need for repeat revascularization, and much lower need for admission for unstable angina. So, if we look at the meta-analysis which was carried out by my friend Sripal Bangalore, it's very clear that the curves are coming closer and closer. The results of Cypher and Texas, the first generation drug-eluting stents, were clearly inferior to bypass surgery in cases of multivessel disease. But the results in the meta-analysis and from the New York registry data clearly shows that if you do a complete revascularization in multivessel disease, do not leave any lesions, diseased vessel not angioplasty, the results are very, very close. Although it needs a randomized study to prove it, but it's very clear for patients with multivessel disease, we have a much better outcome with new generation drug-eluting stents. And if the patient clearly wants angioplasty, I think it can be offered with a nearly equivalent mortality. Restenosis may be high, but we are not clear about that also. So I think we need to have another study. Freedom study was done using first generation stents, but I think we need another study, and in fact we have proposed a study, Freedom India, in which we will be comparing multivessel disease patients, comparing bypass surgery with angioplasty using the new generation everolimus-eluting stent, and that may give us the final answer of this ticklish issue.
So, sir, in a long-term follow-up as a prognosis, bypass surgery versus PCI with the newer stents. So, what's your opinion? There might not be any long-term follow-up studies. What do you feel? I mean,
I think all multivessel disease patients cannot be put in the same basket. Multivessel disease with very complex lesions, we have a score called Syntax score, which tells us about the complexity. And if the Syntax score is more than 32, the complexity is quite high. And in that situation, I think still bypass surgery is superior. But in less complex patients, low Syntax score or intermediate Syntax score up to 32, it appears that the results are quite good, including in left main coronary artery disease. In fact, the study, Excel study, which was presented at a late breaking trial in TCT last month, it was very clear that if the scores are less than 33, the results of surgery and angioplasty were equivalent, and they were not different in diabetics and non-diabetics. So I think the time has come that more and more patients with diabetes, with multivessel disease, can go for complete revascularization with percutaneous interventions like angioplasty with new stents.
Yeah, that's a very good message, sir. I think that's a real hope for the patients, because after all, CABG is a complex and invasive procedure, invasive surgery, and many of the patients, they are reluctant to go for a major surgery like bypass surgery.
"30 to 40% of the patients with coronary artery disease, which we see in the cath lab after angiograms, have diabetes. This is a